Muy buenos días a todas y todos y
Good
bienvenidos.
morning to all of you and welcome to the webinar Designing the Infrastructure Healthcare of the Future, how the COVID-19 pandemic changed the way we think about hospitals. This has been organized by the IDB. This will be a conversation in Spanish.
If you wish to follow the presentation in English, click on the interpretation icon located in the toolbar at the bottom of your screen. Mi nombre es Wilhelm de Laizón, soy especialista en infraestructura social.
My name is William Delezon, and I am a specialist in social infrastructures. During this webinar, we will present the publication Hospitals, Technologies, and Networks After the Pandemic. It's the result of 2 years together between the Health and Social Protection Division and Healthcare with the contribution of health specialists. During this hour, we will have presentations where the experts will talk to us about the most important points, the most noteworthy points about this, and then we will have questions and answers. Please ask your questions through the chat. To begin with, I'd like to introduce Mr. Ibarraban, who is in charge of social protection, who will give us a few words as an introduction. Good morning, good afternoon, wherever you are. For the health and social protection, it's such a pleasure to be with you. We will be talking about a strategic topic, which is very close to all of you and the work you do every day. What are the results of the COVID-19 pandemic for the design of new hospitals? This is a key matter because the pandemic had a very important effect on us. We are talking about many millions who lost their life, of over 1.7 million who died. However, the risk of a new pandemic is right behind our door, and there is always an incredible capacity of its mutation as a virus. As a bank, we had the opportunity to accompany our colleagues in different countries of the region to respond to the pandemic through various investments in infrastructure, equipment, in inputs, and other elements. We also know that many of you participated in the preparation of these responses, and we can say that in spite of the diversity between countries, we were able to identify similar proposals that have motivated us to generate an international dialogue on these two questions. How do we have to design and refit hospitals in order to adapt to rapid and massive changes in the services they have to provide? And on the other hand, how can this refitting of hospitals and the functioning of our networks provide primary attention, primary care in a resolute manner for digital health? In spite of the title of our publication that we are going to introduce today, the design of the hospitals of the future, one of the main lessons in front of us in the health crisis is to conceive a hospital as a part of a network to be able to provide these services and not an isolated issue. I'd like to point out the process of preparation of these documents consists of a number of workshops with experts from Argentina, Bolivia, Chile, Colombia, Ecuador, Spain, Guatemala, Italy, Mexico, and Peru. And through these workshops, we were able to analyze and systematize the experiences so that we could take our recommendations and provide them to you. I would like to end by congratulating all the anonymous heroes that are present and who provided care to patients. They prepared their projects, they executed the work, they purchased equipment and other important items for their patients and protection in the front line. Thank you so much. Thank you, Pablo, for allowing me to speak. Now, to begin, I'm going to give the floor to Carlos Enriquez, who is one of the authors of this publication, and he will present the general structure of this document. He is an engineer and expert in health infrastructure, and he's been a colleague of ours in the protection division. Thank you so much, William. My presentation will center on three of main topics. First of all, I would like to give you the context within which we did this work and the main ideas behind the publication and the methodology that was used to do this work. The first question is, what was the pandemic experience? What did it teach us in terms of guiding the design of the infrastructure for healthcare in the future in Latin America and the Caribbean? We used all of our abilities in order to process and transmit information to provide support to our counterparts in the region. At the beginning of 2020, for example, we developed a webinar with experts from China, Spain, and Italy. These were the countries that were hard hit by the pandemic so that they could share their experience, their challenges, and the problems that they had to face. After that moment, we developed a number of studies and analyses that provided us with a background for this. And what we're trying to do is to take all of those studies and those analyses in order to look at the future to see what it is that was well done and what was not well done, and how we can use all this if we ever have another similar emergency. Let's go on to the next slide, please. As you know, COVID-19 spread very quickly, and it showed us what the weaknesses, what the flaws were in the healthcare systems. At the end of 2022, it had affected 541 million people and caused the death of 6.3 million people. This region was affected with 69 million people that were affected, 1.7 million people who passed away. The equivalent was 2.8 times greater than the world average. And in fact, this had a very strong effect on the fact that we did not have the capacities to be able to face this. And this is a study that was done by the IDB, where it is shown that 2.4% of the population in this region did not have access to healthcare before the pandemic. And during the pandemic, that amount went to 26.6%. Let's go on to the next slide, please. What were the main challenges in this region? Of course, the challenges were multiple, but I can give you a few. For instance, the fragility of the services that were provided, whereas the European countries like Spain, Germany, the Great Britain invest over 8% of their GDP in healthcare. Here we see that it is very low. It's about 6%, which was recommended by the World Health Organization. The heterogeneous nature of the responses, it was quite disparate due to the lack of resources, the emergency plans that were not available, such as the ability to provide physical healthcare. As you can see, there's a lack of beds in these pictures, a population that is much more vulnerable in rural areas, for example, in the Amazon region, where certain communities don't have basic health care, and the migrant population that had to face problems such as a lack of healthcare and the infrastructure. There's a lack of resources, the difficulty of being able to have the isolation measures that were necessary, and a lack of information. How can we respond to these challenges? This is the next question. As we were able to see from the original question, there were many others that came to the fore, and these were the questions that gave a shape to this publication. How can we face demand without suspending preventive services, or how can we include our infrastructure in a situation that is changing constantly? How can we make sure that we can make this sustainable vis-a-vis an emergency that had a peak and kept on going for 2 years, and this created not few problems in our healthcare systems. And from then on, from these questions, here are the four thematic ideas, the key ideas. These are the pillars that sustain this publication. First of all, we realized that we couldn't see a hospital as a unit. We should not have seen it as a unit. In other words, we had to bring all of the various elements together so that this could be transformed in a structure, a network in order to combat the pandemic. First of all, the contribution of health, digital health, which was a very relevant topic in order to combat the pandemic. And in this manner, digital health as a channel of care and coordination became a very important topic. Thirdly, primary health care became a key issue. And in fact, we could not consider hospitals in and of themselves because primary care is the entrance way to healthcare in general. And finally, hospitals, as well as the um, different healthcare centers, also include the setting for support services such as pharmacies and other structures, aside from the extrasectorial sectors that were not health structures that provided the necessary support, such as hotels, gyms, event centers, conference centers, and so on. Very well, then, what was the methodology that was used in order to conduct our publication? As was said, this was a work that we did collaboratively over a span of 2 years. We had 5 workshops. We had over 20 international experts working with us. The idea was to be able to gather all the experience and the knowledge over these years with the actors that were present in responding to the pandemic with the lessons learned so that we could look toward the future. And so we have 5 experts in each of these topics, helped us to distill that knowledge in each of the sectors. Dr. Fabrica, Maria Celeste Savignano, Orlando Pina in primary healthcare, Claudia Romero, Beles Ruiz in terms of infrastructure, support services, and extra sectorial services. I also have to say that this was a very enriching discussion that we conducted during these workshops. There was really a desire to participate, to provide new topics. I have to say that there is no real magical answer to the questions and the problems in each country. They will have to face these issues with their own resources, but this is a guide that provides key concepts and recommendations that are quite interesting. And now we can go on to show you the structure of our guide with a first chapter with the introduction and the groundwork, as well as the lessons that were learned during the pandemic. And all of this is centered on 4 thematic axes. And then we went on to reflections and recommendations. And number 4, we went on to our conclusions. And then we have an axis, which is an annex, which is very interesting, which talks about the successful projects that we conducted during the pandemic. My colleagues will now present each of these conclusions with the recommendations in order to provide you with an idea of the content of this guide. I hope that this helps the decision makers in the region and the healthcare services in general to establish plans and provide answers for future pandemics. Thank you so much. Thank you so much, Carlos. It's very interesting to be reminded of how the countries responded immediately to this situation so that we can start thinking about how we can be better prepared for the future. These thematic axes that were mentioned by Carlos, the structure of this publication are the ones that we will mention. In the first session, we will talk about the network management and the impact of telehealth. We will have some of the authors with us of this publication, Dr. Ricardo Fabregas from Chile, who is an expert in the healthcare sector, providing healthcare services for the Pan American Health Service Organization. And then we also have Dr. Fábricas, as well as Maria Celeste Savignano, who is a pediatrician, and she is an international consultant on health and health service provision. Please, colleagues, you have the floor. Thank you so much. Let's go on to the next slide, please. Very well. They've asked me to provide a summary. We've had some very interesting workshops. The first thing that I have to say is that the document gathers the consensus of all the experts in terms of the importance of health networks during the pandemic and during the pandemic that prolonged itself, not only the Americas region, but other regions as well. We understand and we reaffirm the need for networks. We understand that there has to be an interdependence between the different actors and the disciplines in different places and at different times. We have to work in a coordinated manner to achieve better results. COVID-19 reminded us of the importance of being able to act at different times in the development of this disease. And we have to have coherent answers. It also reminded us that there is a great complexity of the elements that are part of the network. And we have demographics, we have logistic, execution, but just a very long list of issues and factors that have to be adapted to the healthcare in each region based on the pathologies and the problems that we have to face. But what is important is to remember that we have tools in order to face this situation with our networks. And these tools in particular have been used at different times. We've done an analysis based on the tools provided by the IDB. And we've used these because they specialize in characterizing the the um, uh, infrastructure that we have, the characterization of the infrastructure, the continuity of the healthcare, the support services in clinics and non-clinics, and governance as well. I will talk very briefly of some of the lessons that we have learned, that we've extracted from the experience during the pandemic. Of course, we've had certain mistakes, but we also have had successes. And here I will try to provide as much information as possible for the recommendations. In fact, we have to emphasize the fact that there was an imbalance in the initial response. We didn't do everything that was possible because we were learning. We were on a learning curve. We have to face things head on. And this was done during the workshops. We were talking about the errors that we made at the beginning, and we learned many lessons on the fact that many of the emergency networks had to be strengthened. With the months, we were able to do the necessary procurement with the TIC support system, and the territorial initiatives were in place. But it was also important to remember that we were able to do all this. We weren't used to this. And so this was something new in the health sector. And we coordinated the network, and we made that we coordinated the public and private spheres. From these lessons, we were able to extract the recommendations that we will set forth as follows. First of all, we have 4 recommendations that I'm here to provide you with. I would invite you to read these, and they're in the annexes that we provided in this publications. But there would be 4 very important elements on the recommendations that we would be providing. First of all, the need to make sure that the care network is organized based on the natural history of this disease. We have to be able to intervene during this entire curve. First, the second important topic is to make sure that we understand the gravity of the issue on the territory where most people live. We have to be able to understand its characteristics, the measures that we can take, and be able to do this in terms of that territorial reality. We have to be able to do simulation exercises because we react in Latin America rather than being proactive. The experts also said that there is a need to make sure that the domicile is important in healthcare services, in generation of healthcare services, and many things can be done, can be achieved using technology. And another important issue is that the professionals can do things that can be done virtually. So we realized that task shifting was an important element in this case. So there were many doctors that had to come in, and what they did was that they came in to provide support, and there was a mixing of tasks. So I believe that if we had been more proactive and we'd been able to do this, then perhaps we would have a better organization. We would have been able to tackle the pandemic better, and we would have been better prepared to face these issues. In terms of continuity, the emergency networks and the regulator centers are very critical. And this was a learning curve that could be used for other pandemics or for other very serious situations. These are an important conception of something that can be used in the future, in this case in COVID. We also have to understand the elective network. We have to understand the population, and we have to know our population thoroughly. We have to be able to recover the ability to act when it is necessary. And these were situations that we saw in our region, not only in our region, but in the entire world. We have to be able to be proactive, and we have recommendations in this sense as well. In terms of support services, again, the management was integrated to the different teams and the different inputs. Information and contact with the community was another very important topic that not always was very clear in everyday healthcare and management. And another one of these topics was the traceability. This was not a clear concept before the pandemic. And finally, we have to be able to provide governance. There has to be coordination, a responsible organization, as well as a coordination of all of the different factors. This was something that we needed to have in place. We need to make sure that there is a public and private coordination in order to achieve better results, to be able to involve all the relevant actors to provide better healthcare. This is a critical element. I hope I did not exceed the time that was allotted to my intervention. The lessons learned,
Adelante, Rolando.
please. Yes, good afternoon. I will be very synthetic. In terms of the lessons learned in primary health, we should remember that we did not have a response in the initial moments. And then we saw that cases became more and more complex. We were able then to organize our infrastructure. And as Ricardo was saying, there was a reduction of essential services that were not related to COVID. And we needed to make sure that We needed to be able to provide an integral response so that we could cover all health care needs in the entire region. Let's go on now to the next slide. Basically, what was edified wasn't necessarily what was needed. In fact, we had to change our premises in some of the cases in our country. For example, we use different typology of buildings where care is provided to patients based on the territory. But knowing the epidemiology of this disease, we had to separate the sectors because we were not providing the necessary responses. So we decided to have different sectors, and what they did was that they had mobility sectors, the respiratory ones as well as the non-respiratory ones, and then we were able to prevent the contagion in those patients and the personnel. We were able to um, have different teams, healthcare teams that were working with different portions of the population in order to implement new services and to be able to detect and read the reality. The development of this trajectory on change also requires a systematization and a learning curve. In terms of the best practices, I don't know if you've noticed this, but in general, we can say that in the recommendations in terms of architecture are lacking, and they repeat themselves in the next few um, in the next few recommendations. So I centered on the definitions that were taken by the clinical teams, by the different people. The underlying idea was that every single patient and all the healthcare workers were COVID carriers. And this promoted a mutual care. This has a very profound um, effect. And so we had to segregate people, the circulation of people, and this took us to a of a very false sense of security. There were epidemiological studies that required the technical assistance because the communication campaigns were few and far between, and they were confusing. So when we realized all this, we realized that we had to concentrate on our cardiovascular patients, with those that had a very high cardiovascular risk due to COVID-19. So we had to provide training for people that were going to provide outpatient care. We realized that we needed to concentrate on this. We had to learn to decodify the health language. This was a qualitative jump forward. We had to assign the theoretic space to the real space. We had to understand that the physical space had to be rethought. If, for instance, if there were people that were living in a confined space, they had to learn how to adapt and adopt healthcare measures. They had to learn to wash their hands, keep a hygienic measures. And this is something that needed to be communicated. Geo references and the epidemiological analysis were two very important tools that helped some of the teams that were able to break away from the absence of guidelines that were lacking. This as far as I'm concerned.
Very well. Thank you, colleagues. And I'm going to be talking about telehealth and its impact. And among the services that were consolidated during the pandemic, undoubtedly, telehealth is a clear-cut example that allows us to rethink different attention or care channels in health and the way in which we look at hospitals, the distribution of resources. Telehealth can allowed for the provision of essential services that suffered a drop during the pandemic, and it also allowed us to respond to the demand brought about by the COVID-19 pandemic. In Argentina, Colombia, and Uruguay, telehealth represented a mechanism that grew 10 times compared to its use prior to the pandemic. So we saw some lessons and experiences that gave rise for us to consider other types of healthcare services and their provision. We could capitalize on digital tools during the pandemic, and we looked at four positive impacts. The first led to an improvement in healthcare provision to people because we were able to care for them in their homes. This was especially key with people who suffered chronic conditions. Additionally, it was very helpful for clinical interviews, the prescription of chronic medication, and the use of other intelligent devices. Another positive impact from the lesson learned relates to the improvement to community service, such as prioritizing virtual platforms for patients or the use of chat boxes. It also led to the improvement in the coordination and performance of healthcare teams. In this regard, this involved the specialized consultations between different key stakeholders, and it allowed the healthcare teams to be able to work together in the digital space. And this did not just include technology, but a paradigm change in the culture used by the work teams and the focus on the importance of the interdisciplinary approach to healthcare as another positive impact. Another thing led to the health literacy, which was very useful both for healthcare workers as well as citizens in general. We were able to consolidate a common language for healthcare workers and providers, especially those of us who rely very heavily on this service mode. And we cannot neglect the support from IT technologies and communication technologies. When we talk about the digital arena, we're talking about all of the different platforms and technologies that are relevant to healthcare. One lesson learned is related to access to connectivity because this was a key variable that allowed services, and its use now is being proposed as a universal right. In terms of digital health, there are key elements that involve the governments, healthcare stakeholders, hospital systems, and not only healthcare workers, but citizens themselves. Next, we have a number of insights and considerations that we need to keep in mind when we talk about this type of solution. In order for telehealth to yield the expected results, we need to be able to consider other dimensions that look primarily at technologies. That's why it's key for us to ensure proper access to service, considering the geographical, social, cultural, and linguistic gaps, and additionally, the socioeconomic gaps. Some considerations to strengthen telehealth systems, such as the characteristics and the scope of services, we need to ensure that these are patient centric with the potential for a hybrid model and one that capitalizes on integrated health care networks that already exist. In terms of the use of resources to incorporate digital health services, we need to be able to address uh, unsatisfied demands, and we also need to address some of the in-person demand as well. When we talk about an equitable, fair, and inclusive digital culture, we need to focus on approaching technologies and their use with a focus on patients, especially those populations that are most vulnerable. Additionally, we need to establish strategies to be able to properly manage change at the organizational level. Lastly, when we talk about digital architecture and governance, we need to consolidate these by strategically using technologies, processes, and specific elements that focus on emerging needs. A health architecture in the digital space that is deemed to be adequate will allow the different responsible stakeholders at the management level the necessary management capability to be able to set goals that are more clear cut and consider critical inherent factors for the replicability, scalability, sustainability, and permanency of these systems. Thank you very much. Thank you very much to all three. It's fascinating to listen to your insights because it helps us imagine where healthcare services are moving towards, especially as they relate to network management and the use of different technologies such as telehealth will allow us to be better prepared for the future. We will have some time set aside for Q&A at the end of our session. We're going to move on to our second session related to infrastructure, adaptable and flexible design for hospitals. We have three colleagues in this session. Astrid Maria de Bugi, she's a director of architecture and physical resource specialist for healthcare centers from Argentina. We also have Daniela and Claudia Romero from Italy, architect specialized in hospital design. Go ahead, colleagues. Good afternoon and good morning to all of you. Thank you, Wilhelm, for the introduction. The pandemic created a great deal of tension on the region's healthcare systems, which allowed us to observe how hospitals, as part of the totality of the physical resources in the healthcare network, had to face these challenges. Hospitals were an essential element in the response to the pandemic. They played a key role in addressing critical patient needs. The need to immediately adapt the hospitals in the face of a sudden increase in demand led to pointing out clear-cut weaknesses in the installed capacity. Additionally, weaknesses in the healthcare infrastructure. The pandemic highlighted some of the issues in healthcare networks at the global level. Each country needed to reassess its capacities and its potential. Even in the most critical times, we were able to see how poorly prepared our healthcare systems were to face a crisis of this magnitude. Now, in order to overcome these challenges, we needed to use dynamic action, and we needed to focus on flexibility, adaptability, and resilience in all of the aspects to be able to come up with the most effective solutions. Next, we will talk about the following specific topics: the dimensioning, flexibility, circulation flows, access to services, the free areas that are close to hospitals, complementary services, and lastly, the use of physical resources in extra-sectoral health arenas. Thank you. During the pandemic, we realized that we had to provide better support for hospitals to be able to deal with the sudden increase in demand. Hospitals with larger surface areas were able to adapt some spaces to deal with the issue and expanded the areas to be able to house patients and provide services for these patients. So some of these facilities that had limitations in the available space had to adapt by using outside spaces from the hospital. So many healthcare facilities had to avail themselves of whatever resources were available to be able to address their needs. So the question that arose when we talk about dimensioning services is how we could address the sudden increase in demand with limited space and resources, because it wasn't possible to consider the dimensioning of new structures during the course of a pandemic, but it wasn't something that would allow us to address a sudden peak in demand. So what we needed to do was study and observe the demand, not just considering general standards, but the specific needs for the population and other regulatory considerations that guide hospital care services. So one consideration needed to be other potential hospitals as part of the same network. So this assessment needed to be more complete. The hospital needed to come up with the program plan to be able to address emergencies of this nature and to consider potential needs for sudden expansion of services. This plan could include the polyfunctionality of the existing beds or the creation of adaptable spaces, which are areas that could be adapted quickly to address the needs. And these spaces would require the existence of facilities that can be quickly adapted and placed online to be able to expand the response capability to any immediate sudden emergency. Next slide, please. In any case, when we talk about flexibility, when we consider this in the hospital arena, would allow us to undergo these changes in a quick and expeditious way. And it answers the question as to how we can adapt accordingly to address a peak demand issue. And in order to consider these large adaptations for a hospital, we need to consider its design and we need to consider the possibility of readapting the use of space in accordance with the limitations of the hospital to be able to adapt to the conditions on the ground. So this needs to be incorporated into the design. And for this purpose, we have a number of resources, such as the selection of a structural module that is appropriate of 7 to 7.5 or 8 by 8, which would allow you to have a surgical pavilion as well as a radiological space. So this would allow for the adaptation of these spaces to different types of functional modules. This would be necessary when we would have to adapt these specific modules to conditions on the ground without affecting overall function. Additionally, we would need better strategic planning for the hospital facility main areas. Additionally, we would need a better system to recognize the soft areas and hard areas in the entire building. Hard areas would be those that are not movable, such as a surgical pavilion or room, or another hard area would be a radiological room. But soft areas would be those that would be more flexible and adaptable to different conditions. So the identification of these areas, both soft and hard, would be a strategic way in which we could plan for adapting and making some of these spaces more flexible to address the needs. This also needs to include energy issues for the rapid deployment of these areas. We would need to be able to have these possibilities as part of the existing response plan to not try and do things on the fly. So we would need to consider these in the proper context and each of these facilities that are operating normally or under normal conditions need to be also identified in terms of the flexible areas that could be adapted for a larger number of beds or other facilities that are required at any given moment, depending on the scope of the emergency. Lastly, a safer hospital is one that has a clear-cut understanding of flows and infection control. But many times during in an emergency, it's not that easy to identify these flows in both vertical and horizontal directions. COVID highlighted some of these issues, and we needed to ensure the proper differentiated circulations to avoid the spread of the disease. But it was clear that these alternatives were not easy to implement unless you had these considerations previously defined. This is something that the pandemic demonstrated. The most effective way to control infection and disease transmission within the healthcare facility is understanding the materials cleanup and management processes. Many of the issues that occurred in hospitals occurred when these protocols were relaxed. So the personnel and healthcare workers need to make sure that they have their own practices in place for self-care, hygiene, and infection avoidance and control. So after some time, there were some designations made for patients that had COVID and did not have COVID, but we realized that this was not an adequate way to do things because it created a false sense of security both among healthcare workers and patients, given the fact that many of the COVID patients were asymptomatic. And this was a condition that was not yet known at that time. You can move on to Claudia now. Well, very good. I will be next now with a different topic, which involves providing a holistic view to anything related to the hospital setting. Let's talk about access to services. For this purposes, we need to consider the city. The access for patients and personnel to healthcare facilities is absolutely fundamental. The various streets and transportation systems need to be properly addressed. We need to coordinate access. One of the key lessons is that you can't take anything for granted. Access to healthcare facilities, hospitals needs to be expeditious and safe in consideration of different architectural barriers. We need to look at different physical and psychological situations. A patient should not be fearful of going to the hospital. We need to establish the entry points and necessary protocols for the ingress and egress of patients. This is very important. We also need to ensure that we have a proper of documentation systems with adequate digital systems. We also need to properly control external spaces for different types of people. Now, for primary healthcare services, if there's with the adequate IT equipment, they can operate independently. So we need to use these strategies from in order to avoid going to the hospital unnecessarily. Next slide, please. Now, when we talk about free areas that are near hospitals, it's also important for us to talk about these areas to be able to bring about greater flexibility to our service provision infrastructure. So we would need to have a master plan that considers all the levels, the limitations of all services, the resolution of the circulatory or transportation systems, the identification and recognition of all of the key stakeholders that are involved in the process, not just as part of the network, but also internal planning purposes. In particular, at the project phase for external spaces, it's important that we can identify the access points, the execution times, the bringing of these extra hospital facilities online, and ensuring that all support services and staff can access the area without any interference. In addition to some of the workshops, we concluded that it was important for us to identify clear-cut admission protocols based on healthcare criteria and something that includes proper safety measures, which were deemed to be very, very important. Now, this is also a very important aspect. We know that some complementary services involving The provision of services can be undertaken both in a centralized and decentralized way. But during the pandemic given that the impact affected all of these services due to a lack of space and due to an overcapacity, then we were able to favor the use of new technologies. In particular, we're talking about pharmacy services. The strategy for these services needs to consider centralized storage systems that can service other hospitals and other smaller facilities with network systems, digital systems in place, as well as monitoring equipment, inventory equipment, and re-inventorying capability. We also needed to strengthen food provision services as well as maintenance services, and this would lead to an increase in the efficiency of the overall operation of the facility to avoid any additional spreading of the disease. And I speak of this because I live in Italy and in Northern Europe. But when we talk about dispensary services of different materials, gloves, and other medical equipment through automated systems that would allow for a better traceability and hygiene, these systems tend to reduce the actual surface area dedicated to these activities on the facility. So this is a huge opportunity. Some recommendations for the future include the use of automated vehicles or robotics, and this would be prudent for hallways, different loading and unloading areas. But all of this needs to be understood after we have a proper discussion about the needs. As we saw in the prior segment, the flexibility and adaptability of areas for temporary expansion purposes is also important. We also need to identify reserve spaces and the potential need for additional machinery or equipment. Speaking of managing cadavers, this was very clear. First and foremost, we needed a contingency plan for health emergencies that are long term. So we would need to consider the activation of protocols that will go into effect in a timely way. The second change would be through the incorporation of new technologies for transportation, storage, and disposal of cadavers, and to do so in a more flexible and efficient way. And this requires the constant assessment of the installed capacity. We need to also consider the availability of ambulances and other equipment necessary for this purpose, as well as the adequate preparation of the personnel for the proper collection of these bodies. When we talk about healthcare physical resource uses in extra sectoral locations, and this is something that is fundamental for us to have been able to address our sudden increase in the need for beds. And I'm talking about out of facilities spaces that can be adapted to these processes. Now, these prefabricated semi-permanent facilities were the best option that we could put in place in the shortest time frame. In Italy, this worked really well because they are light, they're very mobile and portable, easily built. They have different internal design possibilities that adapt themselves very easily to the spatial needs required for different functions. And this is something that could be located very near a permanent structure. More difficult would be to find the space and different access points, and this requires previous planning and a proper plan. And we always need to maintain healthcare authorities properly apprised of these circumstances so that we don't run into any bottlenecks. And now, disadvantages will include the lack of available outside space. Now, as you can see on the slide, these modules that are temporary facilities that can be built up in a very short time frame and that can be easily adapted to the special considerations necessary for the function to be addressed. Many times, these are facilities that are used for short periods of time. Now, we also looked at sports facilities that have large areas that are covered and that have certain value and certain advantages. These can also be used as adequate quality spaces, but we also need a better understanding of the installed capacity in emergency vehicles. But nevertheless, a large influx of patients can offer tremendous challenges. And all of this requires not only the necessary infrastructure, but the personnel as well. Now, another potential source could be university campuses or some facilities or buildings that are not at full capacity. This was something that we took advantage of in Italy. The lack of it, the disadvantage is that there are many times little or very deficient services available for these lesser used buildings or facilities. Additionally, they don't have proper connectivity to the internet or public utility services. Another important issue is the promotion of hand washing, which was 50% of the struggle in trying to address the pathological load, especially during the beginning of the pandemic. Everything that's been said in the prior sessions also needs to consider the issue of environmental sustainability, economic sustainability, social sustainability, and therefore the participation of the stakeholders, politicians, policymakers, and in this case, healthcare professionals is absolutely fundamental. Thank you very much, Astrid, Celeste, and Claudia. It's amazing how flexibility and adaptability need to be one of the pillars for future facilities design. We don't have any time left for Q&A, but we do have some questions that have been answered in the chat room. And in the publication, we have a great deal of information. I will yield the floor to Ignacio Astorga from the Health Division and one of the co-authors, and I yield the floor to him. Thank you very much, Wilhelm. Good morning to all the colleagues. Unfortunately, the presentations have been excellent, and I wanted to discuss all of, or just give you a summary of everything that we've touched upon. I think that we need to consider that the pandemic implied not just a great effort, but a response that was extremely relevant at the global level. And it's important for us to understand which actions that were undertaken need to continue. And I wanted to try to avoid the post-pandemic amnesia to really take those lessons home. One of them is working through networks. Clearly, the design of a network will determine the volume of demand that a hospital facility will be able to deal with. As Carlos was saying, we could have some less complex clinical issues resolved as part of the design. The second component relates to telehealth. A great deal of the work that we did focused on this new healthcare provision channel. This is no longer a toy or something that operates on the fringes of this arena. This is now a key component of the sector, both for primary and secondary healthcare. And this needs to also be a consideration for future hospital design, the necessary designation of spaces for this purpose. Additionally, it's important for us to have the necessary resources and flexibility for the design. Any attempt to try to really address some of these deficiencies were very complex, many of which were highlighted by the deficient availability of the human resources. So we need to be adaptable, flexible, and we need to be able to work across networks. Thank you very much. Thank you very much, Ignacio. And on behalf of the Health and Social Protection Division, I want to thank all of our presenters and colleagues that contributed their insights. We will try to answer all the questions that we received in the chat room. We'd like to encourage you to access the publication. We've shared the link to that publication. thank you very much, and I wish you an excellent afternoon. Goodbye.